Please welcome Dr. Pardes.
Thank you very much, Kimberly, and thank you all for being here. It's nice to see some familiar faces in the audience, as well as people I hope to get to know during the conversation. The Affordable Act of 2010 holds promise for expanding and improving the health care for Americans. It will also bring deep changes and challenges to our healthcare system. Academic medical centers are leaders in helping health reform succeed. But they'll also be impacted by the health reform of the ACA. We as a nation must avoid actions that may inadvertently damage the unique institutions that have made much of American medicine the best in the world. Academic medical centers reach profoundly into the lives of millions of people with life-saving treatments. They take on the toughest and most formidable medical problems. Their work can seem miraculous. In 2009, a window washer fell 47 stories. A team of nearly 50 academic mental health center people, doctors, nurses, and others, worked to save his life. A 7-year-old girl came to New-York-Presbyterian with a cancerous tumor so embedded in her abdomen that surgeons had to remove all the organs in her abdomen to excise the tumor. They did it and saved her. When the tragic shooting of Congresswoman Giffords occurred, the trauma center at the University of Arizona Medical Center was critical in saving her life. Academic medical centers were created in the early 20th century as partnerships of teaching hospitals and medical schools, and sometimes also schools of public health, dentistry, and nursing. The goal was to combine health research, education, and clinical care in settings focused on innovation and excellence in medical care. Innovation drives academic medicine. The goals are to discover the roots of disease, develop diagnostic procedures, treatments and cures, apply those interventions to clinical use, continue to improve them to achieve even better outcomes, and disseminate new clinical knowledge through teaching, clinical practice, and publication. My own institution, New York-Presbyterian Hospital, is one of the largest academic hospitals in the country, affiliated with 2 fine medical schools, the Columbia College of Physicians and Surgeons and Weill Cornell Medical College, and responsible for some 20% of the health care in the New York area. The innovations developed at academic medical centers are well-known components of the best clinical care. Often academic centers expand frontiers. They try new treatments for the first time. And the firsts have been many. The first polio vaccine, the first successful transplant of hearts, livers, and bone marrow, the development of the intensive care unit for newborns, the first human gene therapy for cystic fibrosis, and many, many more. And this innovation continues today. Stem cell scientists at Harvard are developing functional cells that could have application in cardiac treatment and organ restoration. The University of Pennsylvania is working on the genetic origins of Alzheimer's disease with the hope that new interventions can be developed. There are countless examples of these innovative treatments which have changed medicine. Another key strength of academic medical centers is their comprehensiveness. They typically cover all diseases and medical conditions. They encompass all clinical disciplines. They provide all levels of care, from primary care to the most complicated tertiary and quaternary care, and they transfer new knowledge to the broad healthcare community. These teaching hospitals, or academic centers as we call them, often represent a patient's last hope. Because of their size and reach, they treat large and diverse populations, which exhibit all types of disease and medical conditions, expressed in a variety of economic, social, and cultural settings. They treat the sickest patients and often the most complex cases. A study published in the Journal of the American Medical Association in 1999 looked at the prevalence of 27 high-cost chronic conditions, such as HIV/AIDS and cystic fibrosis, at hospitals in Tennessee. The study found that 22 of the conditions, more than 80%, had their highest prevalence at academic health centers. The academic health centers have what's referred to as the highest case mix index, which is a measure of complexity of disease. A 2004 study at the Institute of Medicine found that 87% of academic medical centers have trauma centers compared to 30% of non-teaching hospitals. 88% have transplant services compared to 5% at non-teaching hospitals, and 95% have open heart surgery compared to 27% at non-teaching hospitals. Academic centers take care of the largest number of the most vulnerable and neediest patients. Though they constitute only 6% of all hospitals, they provide 41% of the charity care, 28% of Medicaid care, and 22% of Medicare. Many academic medical centers, particularly those in urban areas, also provide care to undocumented people who are not covered by health reform. A 2006 study in Health Affairs estimated the national cost of undocumented care to be $6.4 billion in the year 2000. The failure to cover the undocumented will impose an ongoing burden for hospitals. This compromises some of the laudable goals of health reform. America has many fine hospitals: rural hospitals, community hospitals, specialty hospitals. Academic medical centers have special places among that hospital group. They are often the referral sites for other hospitals, patients, in other words, being sent from those other hospitals to academic centers. A recent study by the United Health Systems Consortium showed that even though increasingly sicker patients are being transferred to academic centers, their mortality rate has actually gone down. Academic medical centers are one of America's unique contributions to advancing medical care and achieving excellence. They are both the repository of today's best clinical care and the nation's medical training centers. They hold the promise of tomorrow's medical advances. Now, health reform has three main themes. Number one, increasing access. Number two, improving quality. And number three, reducing costs. Because academic medical centers have long been leaders in transforming medicine, they are well positioned to help lead the transformations that will occur because of health reform. Access will be a challenge. In 2014, 32 million more Americans will have health insurance and will need access to care. At the same time, vast numbers of baby boomers are reaching retirement age and facing the increased medical needs of old age, some 72 million more people by 2020. This growth will place unprecedented demands on the healthcare workforce. The Massachusetts experience with universal coverage offers a sobering example. Wait times for physicians soared, and some doctors simply stopped seeing new patients. The Association of American Medical Colleges projects a shortage of some 130,000 physicians by 2025. Since it takes up to 10 years to train a new doctor, we are already behind. We need at least 6,000 to 8,000 new physicians annually, on top of the 16,000 being produced currently. The shortfall impacts both primary care and the specialties. Medicare offsets only part of the training cost through graduate medical education. In 1997, when the physician pipeline seemed full, Congress capped the number of residencies supported by Medicare. Despite the efforts of political leaders such as Senators Schumer, Nelson, Harkin, Congressman Rangel, and others, the ACA did not include financing to expand graduate medical education. Last November, the Deficit Reduction Committee recommended cutting Medicare funding for graduate medical education by $60 billion over 10 years, which would dramatically exacerbate the problem I've just described if it were adopted. We need measures to increase the healthcare workforce. The caps on residencies should be repealed. We should expand the scope of practice for nurses, physician assistants, and other healthcare providers. Doctors should be trained in quality, in safety, in reducing costs, and in health information technology. We are doing this at New-York-Presbyterian, as are others. Academic medical centers should take the lead in creating the workforce to meet the needs of the new healthcare environment. Now, the ACA also attempts to stimulate quality, another key health reform theme, through value-based purchasing and penalties for hospital-acquired conditions and for readmissions. But measuring quality correctly is complex. Many factors are involved, including the nature of the patients, how sick they are, the quality and quantity of their previous care, underlying conditions such as poverty or lack of care, and other complicating characteristics. These are circumstances facing academic medical centers as a consequence of treating the sickest, most complex cases, as well as the poorest and most vulnerable patients. Without appropriate risk adjustments, value-based purchasing as enacted could wind up rewarding hospitals in more affluent areas and punishing excellent hospitals in challenged communities, where many academic health centers are located. The rules for hospital readmissions could also penalize academic medical centers, which treat the poorest patients with multiple conditions. And as currently written, the rules on hospital-acquired conditions allow for hospitals to actually be penalized twice for the same infraction. Changes in the regulations are needed to correct these inequities. Quality and patient safety go hand in hand. Poorly conceived standards can distort the perception of quality. The Center for Medicare and Medicaid Services, CMS, for example, plans to adopt a quality indicator on accidental punctures and lacerations. The results will be posted on their website for consumers to see and will be utilized in calculating reimbursement. But the metric, again, needs to be risk adjusted. Hospitals with high numbers of medical procedures involving sharp objects or high numbers of surgical procedures, like academic medical centers, may have a larger number of accidental punctures or lacerations. As a result, the academic medical centers may suffer potential financing penalties and lose patients who get a distorted view of quality. With their broad expertise and clinical knowledge, academic medical centers are a strong vehicle for developing and testing quality and safety standards that reflect best practices. A program developed at New-York-Presbyterian, for example, brings hospital management together each Friday morning to focus on safety and quality issues. The group then disperses throughout the hospital to assess compliance levels and help bedside personnel understand best practices. New York Presbyterian residents, too, have formed their own quality councils as a way to give doctors in training a direct role in developing and implementing quality standards. Johns Hopkins' leadership in preventing infections in the intensive care unit, the Partners Hospital's success in using information technology to reduce medication errors. These all indicate the critical role of academic medical centers in achieving new levels of quality. Now, of all the demands of health reform, controlling costs may be the most challenging, especially for academic medical centers. Health reform mandates $155 billion in Medicare cuts for hospitals over the next decade. $50 billion of that is in reduced dish payments for uncompensated and charity care. These cuts were agreed to by hospitals through the American Hospital Association to help fund the ACA. The expectation was that the expansion of coverage will offset that reduction. In some places, that may be true, but it won't happen in states like New York, New Jersey, Pennsylvania, that had extensive Medicaid programs in place before the ACA was passed. The expansion will benefit states that had very little Medicaid coverage. Academic medical centers already take care of a disproportionate share of Medicaid patients, so they will suffer the dish reductions without the benefit of the revenue offsets. The Secretary of HHS should undertake measures to guarantee that the financial equation actually works before imposing large dish reductions. Academic medical centers are also vulnerable to cost-cutting efforts because they seem more expensive than other types of hospitals. But they cost more because they do more. Physician training is costly and only partly reimbursed through Medicare. A hospital teaching and research environment has additional costs of specialized space, equipment, and technical support personnel. Because of their mission to advance medicine and treat the most difficult and complex cases, academic medical centers also maintain expensive programs and facilities, such as specialized emergency rooms, burn units, specialized trauma units, and neonatal programs. Most other hospitals do not have these expenses. There's a danger that in the desire to reduce costs across the board, academic medical centers could be disproportionately impacted because of their higher cost base. If the distinguishing qualities that define academic medical centers are not factored in when imposing cuts, a general leveling down of expertise, innovation, and quality will occur. There will also be a profound economic impact. The combined impact of academic medical centers through the country is more than $512 billion annually and 3.3 million full-time jobs. As other industries have gone overseas and thousands of jobs have been exported, the innovation of academic medical centers in the United States is one of the bright spots of American competitiveness. And technological innovation has been the driver of more than half of American economic growth over the past 60 years, according to economist Robert Solow from the MIT. Academic medicine has been a major contributor to that innovation. In these tight times, there's also pressure to redistribute funding. During the ACA debate in Congress, some argued for shifting reimbursement for supposedly high-cost areas to lower-cost areas, on the grounds that the lower-cost areas produced higher quality. Many of the high-cost areas were in cities and regions where academic medical centers are located, in which they constitute a large part of the care system. But the variations diminish when adjustments are made for such factors as poverty, cultural differences, lack of previous care, mental illness, and behavioral problems. The Institute of Medicine is conducting a national study of variations and taking these factors into account. Quality improvement and cost reduction can be achieved by academic medical centers. Minimally invasive surgical interventions, for instance, is revolutionizing cardiac clinical care. Today, catheter-based insertion of heart valves through the femoral artery reduces the necessary for more extensive, demanding, invasive open heart surgery in some cases. This can result in quicker recoveries, fewer side effects, less chance of infection, reduced and shorter hospital stays. And this is just one example of many ways in which innovations coming out of the academic health centers are reducing the amount of work one has to do in attending to a given healthcare condition. Cost and quality are also linked in improved methods of care for high-cost, high-utilization, chronically ill patients. 76% of Medicare spending is on patients with 5 or more comorbidities. In New York, some 25% of Medicaid recipients consume about 75% of the resources. Often, these patients are among the poorest and most vulnerable, with multiple medical and behavioral issues located in areas of poverty and cultural isolation, which complicates caring for them. Because academic medical centers treat a large portion of such patients, they're well situated to create innovative new care models that will improve quality and reduce cost. The partnerships inherent in the academic medical center structure, hospitals, medical schools, physicians, community clinical networks, schools of public health, and others, provide a creative and experiential resource to develop and implement models of care based on quality metrics and cost control. Many academic medical centers are creating innovative approaches to managing these high-cost patients. For example, the Duke Medical Center at Duke University has developed a health management program called Just for Us that provides in-home visits to seniors as part of an integrated team of care providers. Massachusetts General has built an intervention program for high-cost, high-utilization patients that has reduced Medicare expenditure for this target population by 12%. Emory University Healthcare has developed an innovative system for patient and family management across the spectrum of care. UCLA Medical Center developed a pediatric medical home for coordinating care and has shown substantial reductions in emergency room visits. In our own community at New-York-Presbyterian, we're developing a care model based on data mining to identify the highest cost patients and predictive modeling to see which patients are most likely to be readmitted to the hospital. This is combined with training in cultural competency so that the care providers can better communicate with patients and achieve their cooperation in their care. The strength of academic medical centers and the healthcare system are deeply intertwined. Each one helps the other develop and improve to the benefit of American patients. In this challenging period, academic medical centers can help the nation meet the combined healthcare reform goals of increasing access, improving quality, and reducing cost. Academic health centers, in my mind, have long been the jewels in the crown of American medicine, as Senator Daniel Patrick Moynihan would repeatedly point out to the country. Let me end on a personal note. In the 80s, a colleague of mine at an academic medical center where I was on the faculty was working on the difficult and demanding problem of transplanting livers, a process so new and so formidable that it was not clear how successful it could be. You could think of transplanting a kidney, transplanting a heart, but a liver is a more floppy organ. Can you really do it? And he was challenged any number of times, and he, with other colleagues around the country, persisted. Just a few years later, my own son experienced potentially lethal liver failure. He was saved by the liver transplant technique that grew out of the work of those innovative health professionals. That's why academic medical centers are so vital to all Americans, and why we must do all we can to protect them. They are there to save lives when people need them, as they saved my son, Congresswoman Giffords, and millions of others. The day before a medical crisis threatens you, or someone close to you, the academic medical center may be the least thing on your mind. The day after it becomes apparent that you have a crisis, it could be the most cherished resource in your life. Thank you.
Thank you, Dr. Pardes.